And we're not going to try to resolve what's the right answer to any one question, but we're going to go bang, bang, bang through a bunch of them. There were a bunch of questions about more logistical questions about specific references that were used in some of the slides and availability of the slides. All of the slides that were used today will be posted online at our website. The website's in your agenda book. And so to whatever extent references were listed on those slides, you can access them that way. We'll also, in about a week, have a video online. Peter's shooting a video now, and so that'll be available for you or anybody you know who might be interested to see parts or all of today's program online. So first question, are there evidence-based programs for at-risk kids in our schools? I presume we're talking about evidence-based programs for marijuana prevention. Are there?
Looking at me.
Talk right into the mics.
There are. We have very good evidence-based prevention programs. Not all schools have them. That are clearly with proven efficacy. Most of the prevention programs in the schools, sorry, I'm out of breath, I was late. Most of the prevention programs in the schools now, they're predominantly designed for kids who have not yet started using or who have very limited exposure to substances. They've been shown to be not very effective or even inappropriate for kids who are sort of have already progressed to substance use disorders or have a cannabis use disorder. The thing, there are studies about early interventions. They're very brief, like 2-3 sessions, motivational enhancement interventions. They have a week, a kind of a small effect size, and that attenuates over time. So what doesn't exist in schools is robust substance treatment. We've made advances in evidence-based treatments that we know work for adolescents. They're mostly in the community-based treatment settings. Very few, safe to say that I don't know of any, maybe except for our program, have been adapted for school-based implementation to deliver the services on-site in the schools bell to bell. And to our knowledge, the only one that has integrated mental health substance treatment that's for a research-based would be our Encompass program. But we don't have treatment in the schools, and that's what the biggest gap is, the kids, the 10 to 15% who really need that, and that for existing prevention is not appropriate.
Does anybody else have any comment on evidence-based programs for prevention in the schools?
This is on. Yeah, I just wanted to add that the evidence I've seen suggests a good time to start that is middle school, 6th, 7th, and 8th grade. It's really ideal for that universal primary prevention, and that for people who aren't familiar with that, those curricula, developing social skills actually goes a long way to preventing substance abuse. So sometimes the strategies aren't necessarily totally intuitive to someone not in the field, but developing life skills, which is the name of one evidence-based curriculum.
Let me say, too, that there's a nice symposium that the University of Washington did in Seattle last year or earlier this year. And if you just sort of Google around marijuana and University of Washington, you'll find it. And there's very nice videos on a very nice conference.
I'd add one thing. NIDA has a website, too. That
talk into the mic.
NIDA, the National Institute on Drug Abuse, www.drugabuse.gov, has excellent resources for the evidence-based prevention programs. Life Skills, of course, is one of the ones as well.
The Social Development Research Group at the University of Washington did a review of all the different curricula that are out there right now for best practices to see which ones specifically had evidence for marijuana, and I believe they do have that on the website. They may also be listed on the learnaboutmarijuanawa.org.
There were a lot of questions around the questions around how long marijuana stays in the system, how long it affects driving. What advice should we be giving the public about how long they should wait after using marijuana before driving?
What I've seen has said for smoking something around like 3 to 4 hours, and then for eating, because it's slower to go into the system and slower to leave, maybe something like 6 hours.
What are the specific symptoms of marijuana withdrawal?
Talked about it on Dr. Oz. I guess I can talk about it here. Really, it's only about 30, maybe 35% of people, even who use chronically, will really experience any significant withdrawal. But when they do, it's a documented syndrome and often involves loss of appetite, difficulty sleeping. They may, in fact, lose weight. Kind of flu-like symptoms, may also feel very irritable and experience mood swings. Sometimes kind of nondescript muscle aches, kind of flu-like symptoms. Those are the main ones, and headaches. Those are the main ones that I see in the patients I see. And if you want to know how it peaks, it starts to peak around day 2 of abstinence, slowly drifts down. Most symptoms are gone by the first week, may tail out to 2 weeks, and usually you're done.
What are the possible benefits of cannabis use?
I'll take that.
I thought you might.
I think I did not write that question. Well, we know that there are some. We don't know all of them, and we don't know that much specifically about them. We know that there are some antioxidant properties of cannabis. We know there are some anti-cancer properties of cannabis. We know that there are anti-seizure properties of cannabis. We have not yet figured out exactly how to dose and to give people the kind of medical direction that they need to fully take advantage of these. So it's kind of like just throwing darts at a dartboard right now. It's like you know what you're looking to hit, but you don't really know how to hit that bullseye exactly. But we are, hopefully with more research, going to be able to develop more information about which different components in cannabis are helping these very specific symptoms. With the lab testing, we are starting to do that. And then I would say the other benefit, besides just the benefit of the cannabinoids, is from a public health perspective, the research that I've done on people choosing to use marijuana instead of other substances, such as alcohol or pharmaceutical drugs that pose the risk of overdose death. So I think from a public health perspective, one of the benefits is maybe having folks moving away from more dangerous drug-using behaviors in a harm reduction framework to another drug that has less implications for violence and for other public health issues that we see.
So let me just follow up briefly with that with you or anybody else. Is there in fact good evidence that people do make that trade-off, alcohol for marijuana or marijuana for alcohol?
Yeah, so I've conducted several research studies on this that have been replicated up in Canada. So we have several thousand patients now that we have surveyed about their marijuana use in the substitution context. And we find pretty consistently that about 3/4 of the individuals that are using medical cannabis are doing so consciously to substitute for a pharmaceutical drug, which, I think in and of itself is a public health issue when we see the rise of overdose death in the United States. About 50% claim that they're using it as a substitute for alcohol, and then between about 15 and 26%, depending on the sample, are using it as a substitute for illicit substances. The most common reason that people list for using cannabis instead of another substance is less withdrawal potential, less overdose potential, and belief that it is helping their symptom better than that other substance.
Anybody else have a comment on that? So there were several questions on finances and how the state is going to be using resources, money from marijuana industry. So can you give us a quick summary of that again?
Well, but could I just respond to the last
Okay.
one, just as a quick follow-up? The evidence is not that way in adolescence, though I have to say that there's a growing body of evidence that shows that it may worsen others or increase their vulnerability to substances tried later. So, I think whatever you say about adults, the same is not true of adolescents. It may increase their vulnerability, and there's more polydrug use disorders later in kids who started smoking cannabis, and in that sense could be thought of as a potential gateway.
This trade-off, this conscious trade-off, is not so apparent in youth
No.
as it is maybe in adults.
Doesn't look like
Okay, the money.
I'm glad to answer the next question. The money, there's two pots of money. We have through the medical marijuana program, the cash that's been collected or the fees that have been collected for the registration cards. And that fund has about $13 million in it right now. And so in order to make sure that that money gets spent to the benefit of the folks who are utilizing medical marijuana, I think we and the state have worked to come up with a plan to spend that money. So this is not new money. This is money that's there that we want to spend the bulk of which on research. And so up to $10 million of that 13 would actually be spent on research. Another $1 million or so would be spent on updating the registry system. It's a paper system right now, and we want people to be able to register online and update and renew their applications online and check in their status. And so we have a pretty arcane system in place, remember, from 10 years ago, so it's time to kind of get into this century and spend a little bit more money on that. And then the rest is actually being depleted over time by having us lower the card fee from $35 a year to $15. So the Board of Health actually approved lowering that fee, which is in line with state regs. The second part is through the recreational, I'm not supposed to say that anymore, the legalized adult use marijuana, which is the excise tax money. And again, the majority of that money is to go to capital for schools, and then the rest that's left really, I think, should be spent, and the governor feels, and there's some reg to support this, should be spent on things like education, prevention, regulation, oversight, public safety, all of the things that go along with having this legalized program here in the state. So there's a number of proposals that the governor's supplemental budget proposal, which was submitted a week or two ago, includes things for the Department of Public Health, like we talked about, or like I talked about briefly, which is syndromic surveillance, looking at birth defects, looking at harm reduction, all of these different areas where I think there's still questions. Is it really a gateway? Is it really a substitute? I mean, there's such a great opportunity for us because of the legalization status to learn and spend some money to learn and to educate our kids. So.
Good, thank you. There's several questions about campaigns for kids, and so if we had to focus on an awareness campaign on one area, I'll say hypothetically one area. Of course, we don't do that, but if we did, would it be daily users at risk for dependence? Would it be social smokers? Would it be those who have not yet tried it but are thinking about it? Or is there some other youth-focused awareness target or goal that should be a priority? Anybody, especially anybody who hasn't spoken yet, even if youth work isn't your thing?
I think that question hasn't been answered yet. I think that's what we're still determining. I think we did another.
I know, I'm asking you
right.
Today.
Yeah, today, if we knew, from our lit review in terms of just determinants of youth marijuana use, we only found really 3 kind of substantial studies of those determinants, and because we feel like marijuana needs to be approached differently than other substances. But those determinants were parent communication about that marijuana use and peer use as kind of the major drivers. So when we're looking at our communication, I think we'll be focusing on those 2 determinants.
Any other comments?
And one of the most important things that we could do that's evidence-based, it's easy, our grandmothers would have endorsed this, is that if you can this is both preventative, we use it in treatment, and we use it for relapse prevention or to sustain the gains. That is involving kids in pro-social activities. They're incompatible with drug use, that have, puts them in association with pro-social adult role models and non-using or non-deviant peers. That's an awesome thing to do. We ought to have more activities like that.
And I just want to say something about that. When we were polling the population in California to see where they would want revenue to go if we would tax and regulate in California, after-school programs came out as the number 1 that people really want people to invest in. And I think it's that reason. It's that introducing kids to pro-social behaviors as a resilience building.
Is there a difference between medical marijuana and recreational marijuana, the product itself?
Not really. I don't think I brought this up, though, but the legal limits are different. So if it's recreational or legalized, it's 1 ounce. If it's medical, it's 2 ounces. Unless you have medical necessity, then it could be greater.
question about this heat activation. The specific question is it harmful for a child to eat marijuana if it has not been heat activated? So, but clarify this heat activation question.
Yeah, I think that's what's so unique about what we're seeing nowadays with kids getting into these edible products is because, as we mentioned earlier, those products are baked, they're activated, there's highly concentrated, highly potent, so when these kids are actually getting into them, they're actually getting symptomatic and sick, as opposed to prior to kind of the big movement of the industry, the reports of kids getting sick from marijuana exposures were very far and few between, very sparse case reports, and honestly those case reports were actually from mostly homemade edibles rather than kids actually getting into the bud or the loose leaf plant. So I think that's the difference in the age we live in now as opposed to kind of back then.
Any other comments on the heat activation? There's several questions on secondhand marijuana smoke. So I won't try to repeat the specific questions, but just talk a little bit more, if you would, about what do we know about secondhand marijuana smoke?
Well, one thing I'll say is it's, again, not necessarily the cannabis or even the THC. It's all the other stuff. Just like with tobacco products, there's the potential for all kinds of other chemicals and other things that can be inhaled as part of the smoke, whether you're a primary or secondary smoker of that. So just want to be careful not to sort of make any sort of assumptions about the primary sort of products here, but make sure that people are alerted to the fact that there's a lot of other stuff in there besides just the cannabis and the THC.
David?
So I think, and what I was reading around for this is that secondhand tobacco smoke has been labeled as carcinogenic, or at least potentially carcinogenic, and I think it's because it has the same substances in it, essentially, that Larry was talking about. I think Dan is gone, or he might have made that comment. It's also likely, although I think the evidence is much more sparse, we just don't know, but it's likely that secondhand smoke would have some of the same acute effects on the cardiovascular systems that I talked about this morning in terms of increasing pulse, increasing blood pressure, reducing coronary microcirculation, coronary blood flow, and that sort of thing. But we don't have direct evidence on that, but it seems likely the same effects would be there if the dose were high enough.
Anything else on secondhand smoke? There's sort of a related question, and it gets into sort of occupational and environmental regulations about odors around marijuana production facilities. So what do we know about that?
We do know that at least within our county's code, if we're talking about a grow facility that's on unincorporated Boulder County, that we have some standards around odors, and so that there are requirements around ventilation systems, and so our air quality folks can be brought in for inspections, but it's a complaint-based system for that, and we have found that those grow facilities are finding ways sometimes around particular regulations, and that's that caregiver loophole. So for some of those, if they can't comply with our land use regulations as they apply to a marijuana grow, they'll sometimes kind of flip the switch and say, well, actually, no, I'm not going to do that. I'm going to be a caregiver. So we're still kind of figuring out how we're going to regulate that.
A lot of environmental issues. Is there any evidence of effectiveness in quitline approaches for marijuana cessation analogous to tobacco quitline? I didn't think so.
There's not, but I've been working with Chad Morris, the Division of Behavioral Health and Wellness, and he kind of runs a lot of the quit lines and is involved nationally. And there's some evidence that adolescents or kids who smoke cigarettes, they don't access those quit lines as much in there. But he had preliminary data that indicated that those who were successful quitting smoking may smoke marijuana more. So that it may be, and we certainly need research on this because we don't have any, that we might need to have quit lines for kids for smoking quit lines, whatever you're smoking. You know what I'm saying?
Yeah.
I will say too.
Quit apps.
Yeah. In Colorado, I mean, we did a pilot around pregnant women in smoking with the Quit line here, and some research was done to at least demonstrate on a pilot basis that Quit line can be an effective way for pregnant women to not only quit smoking, but also continue to be smoke-free thereafter. So there may be some lessons learned there as it relates to marijuana as well.
Because of legalization of marijuana, the juvenile justice system has seen a great drop in the number of youth referrals. I guess that's true. I don't know if that's true. How will this affect the provision of treatment to youth with marijuana dependency? First of all, is that true? And then how will it affect treatment?
Sorry, but I don't know if that's true because I haven't seen the numbers on the drops in juvenile justice referrals. I wouldn't doubt it, but it's still, juvenile justice referrals, since they're the largest third-party payer, we're still reaching only the 10% who could be, the 10% of kids. And so we're still seeing big rises in kids in high school who have cannabis use disorders. And so there's very limited treatment options for them. So I don't know, but I know we need to still reach the 90% in some way.
Question about driving performance and these tests. And marijuana has an effect on it. How does the size of that effect compare to other factors like age in driving performance? This was asked by a young person, obviously.
I'm not quite sure. What I've seen is studies that really compare it to effects of other drugs or effects of alcohol, and those studies have highlighted some large odds ratios for alcohol-impaired driving. But if you look at a graph of how age is related to crash risk, it's like 16, 17, and then just drops. So, I mean, age really can't be overstated either as a risk. So if you have kids, 18, wait.
Oh, I was thinking about age at the other end.
And is it the age at the other end?
Yeah.
Older drivers?
Yeah, older drivers
Yeah,
have problems too.
it goes back up at the other end, but it doesn't come close to the 16, 17-year-olds.
Much bigger
Watch out for
effects
them.
being stoned as compared to being old.
Oh, I don't know. I'm just going to put the microphone down.
We'll get the media back in here for you. Several questions around definitions. A lot of terms have been used, like chronic marijuana user, heavy user, and so forth. Is there some sort of consensus about how to define these terms, like a chronic user, heavy user, and so forth? Any consensus in the literature on that or in usage?
There's diagnosis. It's the same diagnostic criteria that we use to diagnose anyone who has a substance use disorder. They're the same criteria that we apply to see if someone has a cannabis use disorder. And those in DSM-5 it changed. We used to have substance abuse and substance dependence. Substance dependence used to be equal to, that's what we mean by addiction, dependence. In DSM-5, everything's categorized as substance use disorder. And so if you have two symptoms, have you persisted in using despite negative psychological consequences? Have you experienced tolerance? Have you experienced withdrawal? Have you had unsuccessful efforts in cutting down your use? Have you used more than intended on occasion? I won't go through all the symptoms, trust me. But we apply those. If you have more than 6 symptoms, it's called cannabis use disorder severe. That would be equivalent certainly to dependence, or what we commonly refer to as addiction.
And then I suppose, go ahead.
Well, I was also going to say that, the amount that somebody's using or the regularity of use doesn't necessarily indicate addiction or dependence either. So, there are individuals that are chronic heavy users of cannabis but would not meet any of those criteria if they stopped using. So, I think there's two separate issues. There's how do we indicate that someone has a disorder around cannabis use, and how do we just measure their use to find out the regularity and intensity that they're using regardless of whether they have dependence or not.